Good morning. My name is Wendell Williams, and I'm an associate professor of anesthesiology at the University of Utah School of Medicine, and I am honored to be a part of the 66th annual meeting and international conference of the Taiwan Society of Anesthesiologists. Medicine is stronger when we work together, and our patients are better for it. Meetings such as this are about systematic improvement through collaboration, innovation, and information sharing. These are the same principles behind enhanced recovery programs. Today I'm going to be speaking with you broadly about enhanced recovery after thoracic surgery, and specifically about the shared experiences of my colleagues at the University of Texas MD Anderson Cancer Center. I'd like to say a special thanks to Drs. Gabe Mena and Jag Singh for their work in this area. We're going to look at recent trends with lung cancer in the United States and globally, as well as discuss certain issues with lung resection surgery. We're going to be talking about the fundamentals of enhanced recovery pathways, and specifically about the enhanced recovery after thoracic surgery program that was developed at MD Anderson Cancer Center. And then we're going to review some outcomes and some of our observations that we've had since the program was started. First, a little bit about myself. I was born and raised in Jacksonville, Florida, which at the time had one of the highest rates of lung cancer per capita in the United States. I received my medical training at the University of Virginia School of Medicine in Charlottesville. I was faculty at the University of Texas MD Anderson Cancer Center for 6 years, and then most recently, I'm at the University of Utah School of Medicine and Huntsman Cancer Institute in Salt Lake City, Utah. As we all know, smoking and tobacco use are associated with lung cancer along with many other types of disease. The good news is that over the last 30 years, the United States and many other countries have enjoyed a significant drop or decrease in the use of smoking and tobacco products, and with that there has been a significant decrease in the prevalence of cancer abroad. However, there is more work to be done. Lung cancer remains a global problem. Every year, the deaths of 10 million people are attributed to cancer. Of those, about 2 million are lung cancer. In the United States, about 230,000 people are diagnosed with lung cancer annually, and about 140,000 of those will die of it. In addition, the rates of smoking in some countries remain persistently high despite overwhelming evidence of the health complications associated with their use. In Indonesia, 2 out of every 3 men smoke tobacco products. And in China, smoking is such that country alone, China alone, consumes more than 1/3 of the world's cigarettes. And a reasonable expectation is with this persistent use of tobacco products, the rates and complications from lung cancer in these countries will be expected to remain high for the near future. While rates of lung cancer have been decreasing, lung resection surgery remains an important part of cancer care. After all, the lung remains a common site of metastasis for many types of cancers. In the United States, there are approximately 530,000 thoracic surgeries performed each year. Minimally invasive techniques now account for 60% of thoracic surgeries. Yet postoperative complications can occur in up to 40% of these patients. Even after uncomplicated lung resection surgery, high variability in practice patterns has been associated with high variability in hospital length of stay and resource utilization. It is this variability in practice patterns, along with an improved understanding of the pathophysiology of postoperative recovery, that led Dr. Heinrich Kellett and others to develop the first enhanced recovery programs nearly 20 years ago. So what are enhanced recovery programs anyway? The individual components to enhanced recovery programs can vary reasonably across institutions. For instance, the individual components of the MD Anderson enhanced recovery programs are specific to the surgical service lines that they involve because they are tailored specifically to the practices of the surgeons and also the needs of the patient population. However, enhanced recovery typically can be defined as a continuous strategy to evaluate and apply evidence-based perioperative practices and protocols to maintain physiologic homeostasis, reduce surgical stress, and improve patient recovery and outcomes. Enhanced recovery programs typically involve the preoperative, intraoperative, and postoperative phases of care. Common components in enhanced recovery programs across institutions include early patient education prior to surgery, as well as selective use of bowel preparation and minimizing prolonged fasting, especially fasting of clear liquids prior to surgery. The intraoperative phase of care typically includes an emphasis on minimally invasive surgical techniques when appropriate, as well as good intraoperative and postoperative regional anesthesia, and a use of multimodal analgesic techniques to minimize the complications of opiate use in the perioperative period. Drains, Foleys, and lines are selectively used and avoided when possible to avoid the associated complications. In the postoperative phase of care, early patient ambulation is encouraged when appropriate, as well as stimulation of gut motility with resumption of oral intake when possible in the postoperative day 0 or 1, depending on the type of surgery. Today at MD Anderson Cancer Center, enhanced recovery programs have been developed and adopted across all surgical service lines. But how are these programs started? Change doesn't always come easy, and this is especially true at large institutions. The first enhanced recovery program was adopted by the hepatobiliary surgical service line, but thoracic surgery soon followed. For the enhanced recovery after thoracic surgery program, a group of key stakeholders, along with thorough support from the other cardiothoracic surgeons, the cardiothoracic anesthesiology section, and thoracic surgery nursing, began the process of investigation and information sharing back in 2015. As previously discussed, Dr. Kellett and others began their work on enhanced recovery programs nearly 20 years ago. In 2014, according to a review of the literature, a total of 38 randomized controlled trials in enhanced recovery were identified. When specifically looking at patients undergoing thoracic surgery, this included 3 randomized controlled trials, accounting for less than 100 patients total. This same systematic review found that enhanced recovery programs were associated with a decrease in morbidity as well as hospital length of stay. However, the results were not consistent because these studies had a great degree of heterogeneity among the different enhanced recovery protocols, the different provisions that were included, as well as patient population, and many other factors that made drawing conclusions on specific patient populations difficult. So yes, the early results were promising, but the science was not complete. Further study was and continues to be needed in this area. As previously mentioned, the Enhanced Recovery After Thoracic Surgery program involves the preoperative, intraoperative, and postoperative phases of care. Important preoperative elements include early patient education, because this helps align patient expectations and improves compliance, and other important elements of the program, such as pre-surgical patient optimization, early postoperative patient mobilization, and pain management. In addition, the preoperative fasting period for clear liquids was modified from 8 hours to 2 hours, and a multimodal opioid-sparing analgesic regimen was adopted. This regimen included gabapentin, tramadol extended release, and acetaminophen. Recently, some changes that have been made based on institutional and other published observations include a dose reduction in gabapentin, and tramadol extended release has been replaced with celecoxib prior to surgery. While the intraoperative management of patients remains flexible and is tailored to the individual based on the judgment of the anesthesiologist and surgeon, there are certain elements within the Enhanced Recovery After Thoracic Surgery program that are emphasized. Intraoperative fluid and hemodynamic management is more often goal-directed based on stroke volume, cardiac output, vascular resistance, and stroke volume variability derived from arterial line waveform analysis compared to standard empiric treatment. There has been a greater use of intravenous anesthetics and adjuncts such as propofol, ketamine, and dexmedetomidine. Perhaps most importantly, the routine placement of thoracic epidurals has been almost completely replaced with a surgeon-performed posterior intercostal nerve block with liposomal bupivacaine, with encouraging results. Prior to the adoption of the enhanced recovery programs, postoperative pain was often managed with the combination of a thoracic epidural and/or an opioid patient-controlled analgesic pump. While patients' pain control was often sufficient, this treatment regimen was associated with a number of possible complications, including postoperative hypotension and excessive sedation that did not encourage or enable early patient mobilization. In the enhanced recovery era, opioid-sparing analgesics have been emphasized, with opioids being reserved as last-line analgesics. The schedules for ambulation and oral intake were also accelerated. At this time, patients are encouraged to get up out of bed and ambulate 6 times per day, and clear liquids are encouraged on post-op day 0 and advanced as tolerated. Tubes such as Foley's and chest tubes are minimized. For example, it had been routine for the placement of 2 chest tubes prior to surgery, and the removal of these chest tubes was considered once output had reached a threshold of below 300 cc's per day. At this time, it is often, but not always possible, for patients to have 1 chest tube prior to surgery, and the removal of that tube is considered at an earlier stage in their recovery. Over the last 10 to 15 years, we have seen an increased adoption of minimally invasive surgical techniques for lung resection surgery. During this same period, many institutions, including MD Anderson, have gone away from the routine placement of thoracic epidurals in favor of more localized regional anesthetic techniques that place the local anesthetic in closer proximity to the surgical site in an effort to minimize systemic symptoms and complications. These are just 2, albeit very important elements of enhanced recovery programs at MD Anderson and other institutions. However, It's important to note that the specific provisions across different enhanced recovery programs may vary based on institutional factors and evolve from institutional data to meet the needs of the institution's patients. The initiation of the Enhanced Recovery After Thoracic Surgery program at MD Anderson had a profound effect on the postoperative opioid use following thoracic surgery. Through the emphasis on multimodal analgesia and posterior intercostal block, the proportion of patients receiving postoperative opioids was cut by more than half. In addition, the total amount of opioids used in the postoperative period was drastically reduced. In this chart, you can see the milligram morphine equivalents over time, starting at post-op day 0 and extending to post-op day 7. And throughout, there is a very clear and profound reduction in the enhanced recovery group compared to the conventional group. Perhaps one of the most encouraging early results from the enhanced recovery program was its impact on opiate prescriptions at discharge. The so-called opioid epidemic of the United States and other countries has been well documented, and patients undergoing lung resection surgery are no exception. Indeed, postoperative pain following lung resection surgery has numerous etiologies. Along with the surgical incision, there is possible trauma to the musculature, ribs, nerves, pleura, and pulmonary airways. Patients can then develop chronic pain, what is called post-thoracotomy pain syndrome, which is a complex and possibly debilitating pain of the chest or incision that persists for longer than 2 months following surgery. Underdiagnosed and difficult to treat, effective regional anesthesia along with systemic multimodal analgesia can reduce but not completely eliminate the development of chronic pain. Nevertheless, our results were encouraging because we were able to reduce the number of patients being discharged with opioid prescriptions in half, from 80% in the period from 2007 to 2012 down to 39% in the enhanced recovery era of 2015 onward. The initial data from the Enhanced Recovery After Thoracic Surgery pilot program was promising and supported the complete adoption of this program going forward. The question remained, would enhanced recovery do more than reduce opioid consumption? Could it actually improve clinical outcomes in our cancer patient population? Enhanced recovery is about continuous data collection and improvement, and therefore further study was required. So we looked at 2,800 patients undergoing thoracic surgery at MD Anderson over a period of approximately 10 years. 1,600 of these patients were from the pre-enhanced recovery conventional era that occurred between 2007 and 2012, compared with 929 that occurred in the transition period between 2012 and 2015, and 342 patients who were part of after the full enhanced recovery program was adopted in 2015 going to the end of 2017. When comparing these groups, there was significant difference in the number of patients receiving thoracic epidurals and minimally invasive surgical techniques. This change in practice patterns at MD Anderson mirrors that of many other institutions and therefore was expected. Non-parametric analysis and multivariable logistic regression were used to compare outcomes such as hospital length of stay, admission to the intensive care unit, complications, and mortality. When comparing the groups, we found that length of stay and admission to the intensive care unit were less in the transition and enhanced recovery groups, as was pulmonary and cardiac complications, including atrial fibrillation. Of note, the increase in gastrointestinal complications was found to be primarily driven by diarrhea, perhaps associated with a decreased use of opiates. When looking specifically at patients undergoing open thoracotomy, patients in the transition and enhanced recovery groups had a clinically and statistically significant reduction in their hospital length of stay, as well as the rate of admission to the intensive care unit. The patients in the transition and enhanced recovery groups also had a lower rate of cardiac and pulmonary complications. The beneficial associations of the enhanced recovery program were also more prominent in the open thoracotomy groups as compared to those undergoing minimally invasive surgical techniques such as video-assisted or robotic-assisted thoracoscopic surgery. So what happens when we look at patients undergoing minimally invasive surgical techniques? One could hypothesize that these patients would be undergoing a less severe physiologic insult during their surgery, and therefore potential benefits of enhanced recovery programs could fail to be clinically significant. What we found was that when looking at the pre-enhanced recovery, transition, and enhanced recovery groups, there still was a downward trend in hospital length of stay that did achieve statistical significance. However, some of the other observations that we had seen in the open thoracotomy group, such as differences in admission rate to the intensive care unit and cardiopulmonary complications, failed to reach statistical significance. The authors also looked at some other clinically significant outcomes, such as discharge with test tube or home oxygen, postoperative pneumonia, and atrial arrhythmias. While the trends did vary somewhat during the study period of 2007 to 2017, there appears to be a statistically significant trend in reduction of these postoperative complications as the group practice transitioned into the enhanced recovery program. Well, if enhanced recovery programs are intended to maintain physiologic homeostasis to improve patient recovery, how does it do in the cancer patient population? How does it fit within the patient's oncologic treatment protocols? And does it affect their schedule to complete systemic adjuvant therapies? In this single institution retrospective study that was completed at MD Anderson, patients with fairly early stage non-small cell lung cancer undergoing lung resection surgery with curative intent were evaluated. Inclusion criteria also included the patients ending up with a 5 centimeter or larger tumor size or positive nodal involvement based on pathologic assessment. In total, 471 patients met the inclusion criteria and who would therefore qualify for receipt of adjuvant chemotherapy per the National Comprehensive Cancer Network guidelines. Again, patients from pre-enhanced recovery era 2006 to 2012, the transition period 2012 to 2015, and the enhanced recovery period 2015 to 2017 were included. Univariable logistic regression was used to evaluate factors associated with the receipt of adjuvant chemotherapy. Covariates with p-values less than 0.25 were entered into multivariable analysis. The covariates analyzed included age, extent of resection, the enhanced recovery era, surgical approach, pathologic T and N status, American Society of Anesthesiologists status, preoperative performance status, percent predicted FEV1, tumor grade, and histology. In order to compare postoperative patient recovery, the ECOG, or Eastern Cooperative Oncology Group performance status, was evaluated between the three groups. Specifically, the time that it took the patients postoperatively to return to an ECOG status of 0, meaning full activity, no performance restrictions, was evaluated. In this comparison, the transition and enhanced recovery programs were associated with earlier and more profound return to full activity. So we know that patients in the transition and enhanced recovery groups had a quicker and more complete return to full activity following lung resection surgery. The authors also observed a statistically significant reduction and the postoperative days to the initiation of adjuvant therapy that began in the transition period and continued through the enhanced recovery period. Well, it's one thing to start adjuvant therapy, but we know that cycle completion is also a very important factor in patients' overall survival, generally speaking. It makes sense that the number of completed cycles of planned treatment correlates with both progression-free and overall survival. In this study, an increasing proportion of patients in the transition and enhanced recovery groups were able to complete their adjuvant regimen. So not only were patients in the enhanced recovery after thoracic surgery program able to recover more quickly, this recovery was associated with statistically and, most importantly, clinically significant endpoints such as the initiation and completion of adjuvant therapy. Conclusion: lung resection surgery remains a common and important part of oncologic care, but unfortunately it's associated with a relatively high rate of morbidity. Enhanced recovery is an evolving evidence-based and collaborative strategy to maintain physiologic homeostasis and improve patient outcomes. Like many enhanced recovery programs, the Enhanced Recovery After Thoracic Surgery program at MD Anderson emphasizes patient education, patient optimization, multimodal analgesia, minimally invasive procedures and lines, and early ambulation. This program, as we have seen, has been associated with decreased complications, shorter hospital length of stay, reduction in perioperative opiates, improved postoperative functional recovery, and very clinically significant decreases in the time that it takes to initiate and complete postoperative adjuvant therapy. These results are promising, but they are by no means a complete review of the enhanced recovery after surgery literature out there. Much good work is being done at many institutions across the globe. That said, large, well-designed, multi-center trials are necessary to further refine and optimize the provisions within enhanced recovery after surgery programs going forward. Thank you for inviting me to participate in your meeting and to discuss enhanced recovery after thoracic surgery and the experiences of my colleagues at MD Anderson Cancer Center. I look forward to the discussion to follow. Thank you.